Is a 38 years old female who had a brain tumor for which VP shunting was done in 2004. In 2005, she was comatose for 3 months, then bedridden for 8 months and developed stiffness of both the hips. Some corrective osteotomy was done in 2014 with implants, which was removed in 2015, a year later due to loosening. She had sustained some injury to the cervical spine and posterior instrumentation was done. Practically, she is bedridden since 10 years, inability to walk due to hip stiffness. That was the clinical findings. Left hip surgical well-healed scar. Left hip fixed deformities, flexion 30, adduction 30 and internal rotation of 20 degrees. Left knee has got a 60-degree range of movements. Right hip was fairly good range of movement, 30 to 110, abduction 20, adduction 10, but rotations were restricted. Right knee has got a very good range of motion, about 120 degree. There was palpable quadriceps and abductor contractions and intact neurovascular status. Those are the X-rays, AP view of the pelvis with both hips and attempted lateral view of the hip there. So, what would you do?
So now she's been bedridden for how long? You said 10?
Almost 10 years.
10 years. So I think first, from the panel, maybe just, goals of care, for us, the goals of care for her. What are her goals? Is it to sit upright in a wheelchair? Is it to transfer? Is it for other, perineal care? What are kind of limitations that she has now where you're considering a surgery to help her functionally?
Now she is conscious, well-oriented, she wants to, ambulation.
Yeah. What does the panel think about bedridden for 10 years? She's young, that's in her favor.
But but because of the, brain tumor, she was operated, she was comatose after the surgery, and for which she has recovered all these things, and now she's quite okay.
Okay. Just from muscle conditioning, anyone on the panel want to comment on that, or you think there's a chance for her to actually walk again with her history?
See, she's the patient is bedridden for such a long time.
Years, yeah.
So I would think of other options also other than arthroplasty. Because if she wants, like you said, prenatal care, sitting, why not just do a girdle stone and leave it? Or some people who are good at it may think of a pelvic support as short knee later on because patient is young and the type of profile patient has, they want to sit cross-legged, sit, in India. So doing a total hip is an option, but I would like to know the patient profile, like would it really benefit? Chances of dislocation after having a brain trauma and weak muscles.
Yeah.
I would think about a correction osteotomy of the left hip and let it stiff, let it with this ankylosis and total hip on the right side. If she is painful over there, probably you can bring her up. But I would do a correction osteotomy due to hygienic reasons. She will get more and more problem to do their daily hygienic work, and I think a correction osteotomy is the best. You can, of course, try to perform an arthroplasty on the left side, which is possible, but at least in my hands, the results are not really good.
Yeah, I think I would like to do a total hip if the patient demands so, and we would have to use a modular stem with the corrective osteotomy in the subtrochanteric region, where the deformity can be corrected in both the planes, and use a modular stem where I can restore the offset with the standard cup.
Okay.
I think before we plan a total hip, we need CT scans in this case, because we need to seek very carefully where the HO is and plan the HO excision first.
Yeah.
Okay.
Would anyone also get an MRI? Or you said the abductors were palpable. Does anyone think an MRI is valid to look at muscle tone? Is it all fatty infiltration? Does anyone do that when they're assessing a hip that's been fused for so long?
Not in the routine practice, no.
Not routine.
I would agree with Dr. Noop to do a CT scan to see the HA and the approach to be used accordingly.
Okay.
And though the pulses are palpable, but if the HO is more anterior, then we should do a CT angio as well to find out if the HO excision will come in our way of the vessels.
So these are the knee X-rays which shows there is a ectopic bone formation below the medial collateral ligament on the medial side in both the knees, and those are the CTs. I'll just go through the CT quickly. There are HO mass anteriorly, there is HO mass posteriorly, and it was there superiorly, and it was both anterior, posterior, and superiorly the HO mass is there.
So, thoughts, assuming, I mean, we're going towards arthroplasty, if that's the way we're going to be going. What are people's thoughts in terms of surgical planning? Is this one approach, one incision? Is this two incision? In terms of HO takedown, neurovascular protection, mobilization, and then of course we have to talk about the corrective osteotomy component. But just for exposure and just the takedown.
So this patient has a flexion, internal rotation, and a adduction deformity. So I think the HO mass is, although anteriorly more, I would still go with the posterior approach, and if needed, go anteriorly and excise the HO.
Okay. So you would start posterior and only go anterior if you weren't able to mobilize.
Yes.
So will you do at one stage or two stages?
One stage, dual approach maybe.
Okay. Any other thoughts?
I think I agree with Mridal. I'll be ready with the dual approach. Probably I'll have to go and posterior approach incision, but be ready for going in the front and do an inside to neck cut, get the acetabulum right, and then be prepared for the osteotomy for the proximal femur. Use a stem which can get a right trajectory, because I'll have to do an osteotomy at the proximal femur. And since the dislocation rate would be high, maybe worth considering a dual mobility or stuff like that.
Okay. You said the bone stock, the HO was anterior and posterior, you said, right? Circumferential, so challenging to get access through one incision. Thorsten, any thoughts on that?
Exactly. I would, if I would do it I would go for an arthroplasty. I would do it in a two incision technique, posterior and anterior, because you have, as you said, this bone formation, massive bone formation, also in the anterior part.
Okay.
So the problems is that there is an unsound ankylosis, there is ectopic ossification, there is a deformed proximal femur because of the previous osteotomy, and patient is bedridden, requires mobilization. We did a serum alkaline phosphatase because just to ascertain that it remains within normal limits, that HO is a matured HO. Then this is the positioning of the patient, lateral position. We went by the. Then this is the abductors, which are quite healthy and quite intact abductors. So what we did, we planned to do a trochanteric osteotomy, so trochanteric flip osteotomy, so that we could approach HO anteriorly as well as posteriorly. And as you can see this structure, this is number one, what we did, trochanteric flip osteotomy. So we took the trochanter along with the abductors away, and that would correct the deformity as well. Then this was the anterior HO mass. So we came across the anterior HO mass, then we excised the mass anteriorly as far as possible near the acetabulum. Next, the neck was demarcated. After excising this mass here, this is the neck. Then you did a napkin ring osteotomy of the neck. So this is the napkin ring osteotomy, or a segmental osteotomy, so that you can mobilize. But there was a posterior HO mass as well. So we excised the posterior HO mass, then the shaft was free. So then the acetabulum was right away in front of this. We just curated out because the bones were very soft, and the acetabulum, the head came out like a cell-like manner, and that was the acetabulum which was exposed. As rightly pointed out Dr. Sharma, I used the dual mobility because there are high chances of dislocation. So the dual mobility cup there, and that is the stability on the table, flexion, abduction, and external rotation, and that is flexion, adduction, and internal rotation. The cup size was 44, stem was 14 in 190 Wagner, head was 22 metal, dual mobility, and of course we did a adductor tenotomy. Then we did a trochanteric wearing, and post-operatively we gave one single dose of radiotherapy, 8 gray, and then indomethacin 25 milligram TDS for 6 weeks. And this is just a 6 weeks follow-up of this patient. The knee HOs were excised through a small incision. So that was a bedridden patient, now is mobilized with the help of the walker.
Beautiful.
That is the lateral view.
Beautifully done. Great. I think
Just a couple of literature. We had published, post-encephalitic viral heterotrophic ossification in 15-year-old female, where he did an excision, and we published as a case report in Journal of Pediatric Orthopaedics that we excised and gave a post-op radiotherapy in 2 years follow-up, so the excellent function. There is a publication, resection of the heterotropy ossification around hip after trauma in Journal of Effort following head injury, and they have coined the term osteoplasty by the only excision of the HO. And finally, in recently, April 22, one case report has been published, a 56-year-old male, history of posterior dislocation of the hip in 1996, dual mobility THA has been done, but follow-up has not been mentioned. So take-home message, heterotopic ossification around the hip follows encephalitis, head injury, hip trauma associated with prolonged immobility states. Excision or osteoplasty is if the joint space is maintained. Total hip arthroplasty if the joint space is affected. Approach needs planning in each and every case and has shown an excellent functional outcome. Thank you for a patient hearing.